You swallow a tablet every morning without giving it a second thought. It takes barely 10 seconds, and you've repeated that same routine every day since the day your doctor first wrote that prescription. But if you're past 60, and that tablet happens to be a calcium channel blocker, an ARB, or an ACE inhibitor, there's a strong possibility that something is unfolding inside your body that was never fully explained to you the day you picked up that bottle from the pharmacy. Let me tell you about a man I'll call Arthur, 76 years old, a retired school administrator, meticulous about his health, who had been on his blood pressure medication without missing a single dose for over a year. His wife phoned me one afternoon, and I could hear the worry sitting heavy in her voice. She told me her husband had quietly stopped attending his weekly church gathering and that his legs no longer looked like his own. Arthur hadn't suffered a cardiac event. He had spent 3 months silently convinced something catastrophic was happening to his heart, and out of embarrassment over how swollen his legs had become, he'd started skipping doses on the days he needed to be out and about. That silence nearly cost him everything. I'm a cardiologist with more than 3 decades in clinical practice, and what follows are the things I believe every older adult on these 3 common blood pressure medications deserves to understand. Not because any doctor is withholding information deliberately, but because a rushed office visit rarely leaves room for the kind of explanation this topic actually requires. Before continuing, I'd genuinely like to know, have you noticed changes in your body since starting blood pressure medication that you brushed off as simply a normal part of aging? Sharing that might help someone else reading who assumed they were the only one experiencing it. Most people describe the same kind of first appointment: a short conversation, a diagnosis delivered in 2 words, a prescription for once daily use, and an instruction to return in a few months. Rarely does that conversation cover what's actually changing inside the blood vessels, or how a 70-year-old body responds differently to these drugs than a much younger one. People walk away with an incomplete picture, often assuming the pill alone is solving the underlying problem. The reality is more nuanced than that. These 3 types of medication all lower blood pressure, but they work through entirely different biological pathways, which means they carry entirely different side effects and warning signs. Misunderstanding that difference means misreading what your own body is trying to tell you. The calcium channel blocker works by limiting how much calcium enters the smooth muscle surrounding your artery walls. Less calcium flowing in means less tightening of those vessels, and pressure drops. It doesn't undo the years of stiffening that caused the vessels to tighten in the first place. It simply manages the resulting output. The ACE inhibitor works upstream, blocking the enzyme your body needs to manufacture a substance that narrows blood vessels and tells your kidneys to retain fluid. Cutting off that enzyme is like shutting down the factory that produces the tightening signal altogether, and because it eases pressure on the kidneys as well, this class is often favored for older adults dealing with both high blood pressure and early kidney concerns. The RB targets the same pathway, but at a different point. Instead of stopping that tightening substance from being made, it blocks the receptor doorway that substance needs to act on the vessel walls. The message gets sent, but the door it needs is locked. One key distinction between these 2. ACE inhibitors are far more likely to cause a persistent dry cough, which is precisely why physicians frequently switch a patient from one to the other. Not because either drug is weaker, but because nobody should have to tolerate a cough interrupting their sleep every night when an alternative exists. Let's talk about the ankle swelling associated with calcium channel blockers, because this is the conversation Arthur should have had long before he stopped leaving his house. This class of medication relaxes the small arteries in your legs more than it relaxes the veins, so blood moves in easily but struggles to drain back out, and fluid accumulates in the surrounding tissue. It's why your shoes feel fine in the morning and uncomfortably tight by evening, and why the swelling resets overnight. It isn't a sign of heart failure or kidney damage. It's a predictable mechanical side effect of how the drug acts on your lower limb circulation. What made Arthur's situation genuinely dangerous wasn't the swelling itself, but his silence about it. He'd been quietly skipping doses out of embarrassment, and his blood pressure had been climbing unchecked for months as a result. Always report swelling to your doctor rather than hiding it. Skipping your medication is far riskier than living with mild swelling. If you're on an ACE inhibitor, pay attention to whether a cough has developed since you started it. Not a wet, productive one, but a dry, scratchy, persistent tickle that nothing seems to soothe. The tricky part is that this cough doesn't always appear right away. Sometimes it surfaces months into treatment, by which point most people have stopped connecting it to their medication at all. They blame seasonal allergies, dry indoor air, or acid reflux, replace household products, and never once suspect the pill bottle sitting on their counter. One patient I treated, a woman in her late 60s, spent 4 months assuming her nagging cough was caused by something in her home before we traced it back to when she'd started her medication. A dry cough alone isn't an emergency, but it should be reported. What absolutely cannot wait is any swelling of the lips, tongue, face, or throat, particularly if it becomes hard to breathe or swallow. That is a rare but potentially life-threatening reaction to ACE inhibitors, and it requires immediate emergency care. There's also a risk hiding not in your medicine cabinet but in your kitchen. Both ARBs and ACE inhibitors can raise potassium levels in the blood, which affects your heart's electrical rhythm, sometimes with no warning symptoms at all, beyond mild weakness or an occasional skipped heartbeat. Many heart-healthy salt substitutes replace sodium with potassium chloride, and the same goes for various electrolyte powders and senior nutrition drinks, all of them quietly adding potassium to a system that's already retaining more of it than usual. One patient of mine switched to a potassium-based salt substitute, believing it was the healthier choice, without realizing it conflicted directly with his ARB prescription, and ended up with dangerously elevated potassium levels. He hadn't been careless. He simply hadn't been given that piece of information. Read the labels on anything marketed as heart healthy, and ask your doctor directly whether a potassium-based salt substitute is safe, given your specific prescription. Check your bathroom cabinet as well. Regular use of over-the-counter pain relievers like ibuprofen or naproxen, especially alongside an ACE inhibitor or ARB and a diuretic, can reduce blood flow to the kidneys and raise the risk of kidney injury. Not because any single one of these is inherently dangerous, but because combined, in a body that's even mildly dehydrated, they place a strain the kidneys can struggle to manage. This rarely comes up in appointments simply because over-the-counter pain relievers don't register as real medication in most people's minds. Ask your pharmacist directly whether regular ibuprofen or naproxen use is safe given everything else you're taking. It costs nothing and could prevent a problem nobody saw coming. If you're on an ARB or ACE inhibitor and you become ill, vomiting, diarrhea, heavy sweating, unable to keep fluids down, understand that the same dose that worked perfectly yesterday can behave very differently today. These medications are designed around a body with stable fluid levels, and when illness disrupts that balance, blood pressure can drop further than intended and place added stress on the kidneys. One of my patients, an otherwise disciplined 78-year-old, continued taking his usual dose through a stomach virus simply because he hadn't missed a single dose in over a year, and later that night nearly fainted after standing up. The lesson worth writing down somewhere visible. If you can't keep fluids down, call your doctor before taking your next dose. It's also worth remembering that the most concerning blood pressure reading isn't necessarily the highest number you've ever recorded. It's the one taken at the wrong moment, under stress or anxiety, that gets mistaken for a verdict. Blood pressure naturally fluctuates with sleep, caffeine, posture, and the simple anxiety of checking it too often. One woman I treated was convinced her medication had stopped working because of erratic readings taken throughout the day whenever she felt anxious. Once we standardized her measurements, same time, same arm, 5 minutes of rest beforehand, a much steadier, reassuring picture emerged. The chaos had been in her measuring technique, not in the medication. Take your readings consistently, at the same time and in the same position each day, and respond to patterns over time rather than any single number. 2 people can be the same age, on the same dose of the same medication, and see completely different results, because the medication is only half of the equation. The internal environment it's working within matters just as much. A high-sodium diet forces the medication to work harder against constant pressure. Poor sleep raises stress hormones that tighten the very vessels the drug is trying to relax. Excess weight adds cardiovascular strain no medication alone can fully offset, and inactivity allows artery walls to stiffen further over time. When your daily habits work with your medication, results tend to stay stable. When they work against it, doses often need to climb. Not because the drug has failed, but because it's fighting an uphill battle. After 30+ years of practice, the single most important truth about these medications is the one rarely spoken aloud on the day the prescription is handed over. None of them cure the underlying condition causing the high blood pressure in the first place. They manage the output of a system without repairing the system itself. That's precisely why regular follow-up matters, why lifestyle changes aren't optional extras, and why a good number on a chart doesn't mean the conversation is finished. The patients who tend to do best aren't necessarily the ones on the most medications. They're the ones who understand exactly what their medication is doing, what it isn't doing, and who actively work with both realities at once. As a simple framework, if you're on a calcium channel blocker, keep an eye on evening ankle swelling, lightheadedness on standing, or flushing, and report it rather than skipping doses to hide it. If you're on an ACE inhibitor, watch for a dry, lingering cough that may appear even months later, and treat any swelling of the lips, tongue, or throat as a genuine emergency. If you're on an ARB, check the labels on anything marketed as heart healthy in your kitchen, stay alert to muscle weakness or an irregular heartbeat, and ask when your potassium levels were last checked. Across all three, avoid regular ibuprofen or naproxen use without checking with your doctor first. Call ahead if illness causes fluid loss. Measure your blood pressure consistently rather than reactively, and never stop any of these medications abruptly without medical guidance. As for Arthur, once his wife's call prompted a proper conversation, we adjusted his routine, reviewed his diet, and, most importantly, actually sat down and walked through everything above. Within a few weeks, his swelling was under control, his blood pressure had stabilized, and he was back at his church gathering that Sunday. He later told me he'd spent 3 months terrified over something that had a name and a simple explanation all along. He just needed someone to walk him through it. Months later, he shared a simple written summary with a group of men from his congregation. Several went on to raise questions with their own doctors they'd never known to ask, and more than one overdue medication adjustment came out of it. After all these years in cardiology, I remain convinced of one thing. The people who manage their blood pressure most successfully aren't the ones taking the most medication. They're the ones who genuinely understand what's happening inside their own bodies and use that understanding to make better decisions every day. Information isn't an extra step alongside treatment. It is part of the treatment. So before your next reading, ask yourself honestly, do I actually understand what my medication is doing inside my body and what it isn't doing? If the answer isn't a clear yes, that's not a failure on your part. That's simply the gap worth closing.